Bismillah ar-Rahman ar-Rahim. This is Mohammad Abdelghani from Al-Azhar University, Cairo, Egypt, and Amsterdam University Medical Center, the Netherlands. It's a pleasure to present to you today on percutaneous mitral commissurotomy. As we know, patients with organic mitral valve stenosis who have significant leaflet fibrosis and commissural fusion are suitable candidates for percutaneous mitral commissurotomy. The typical phenotype is rheumatic mitral stenosis. On the other hand, patients who have basically annular disease or supra or subvalvular disease, such as in mitral annular calcification, congenital rings, and so on, these patients are not perfect candidates for percutaneous mitral commissurotomy. Balloon valvuloplasty has several names, including balloon mitral valvuloplasty, percutaneous mitral commissurotomy, and percutaneous mitral balloon commissurotomy. And the possible options to treat such a condition, if it is severe and causing symptoms and or complications, are either percutaneous approach with balloon valvuloplasty or surgery. The first line of treatment is percutaneous valvuloplasty. Surgery is basically reserved for patients who are not suitable candidates for the percutaneous approach. And by surgery, we basically mean mitral valve replacement, as surgical repair is seldom suitable because of the extensive disease of the leaflets and the subvalvular apparatus in the majority of patients. If we summarize the indications for percutaneous mitral commissurotomy, these can be summarized in a couple of scenarios. The first, most common and most established scenario is a patient with moderately severe mitral valve stenosis with an area of less than 1.5 centimeters square who has a favorable anatomy. Such a patient should be offered percutaneous mitral commissurotomy or if she or he has symptoms or risk factors of hemodynamic deterioration and or irreversible adverse cardiac remodeling, such as significant pulmonary hypertension, or risk factors for thromboembolism, such as recent or paroxysmal atrial fibrillation, prior systemic embolism, or dense spontaneous echo contrast in the left atrium, or if the patient is planned to undergo a stressful situation, such as a major non-cardiac surgery or pregnancy. In patients with unfavorable anatomy, these patients should proceed to surgery if they have severe symptoms. However, percutaneous mitral commissurotomy can still be considered if there is high surgical risk, or the patient is pregnant at the time of severe symptoms, or if the patient refuses the surgical option. In patients with very severe stenosis and an area of smaller than 1 centimeter square, if these patients have favorable anatomy, one may consider percutaneous mitral commissurotomy even before the development of symptoms or complications, in order to seize the opportunity before the anatomy deteriorates or adverse remodeling ensues. Another much less established scenario is a patient with apparently mild mitral stenosis with an area of 1.5 centimeters square or greater. If such a patient has severe symptoms that are otherwise unexplained, one may consider performing exercise echocardiography. And with exercise, if the transvalvular gradient rises significantly and the pulmonary artery pressure rises to a high degree, this may suggest that mitral stenosis is hemodynamically relevant, and some physicians may consider percutaneous mitral commissurotomy as a therapeutic option in this scenario. Another difficult scenario with difficult decision making is a patient with apparently mild mitral stenosis and otherwise unexplained severe pulmonary hypertension. In such a patient, we may consider to invasively document severe and to verify that pulmonary hypertension is really severe. And if this is confirmed, pulmonary capillary wedge pressure should then be measured, and if it's raised and is not explained by anything but by mitral stenosis, in this situation we may also consider percutaneous mitral commissurotomy as a therapeutic option. Regarding the contraindications of percutaneous mitral commissurotomy, these include greater than mild MR, because this will likely proceed to severe MR after dilatation, patients with an indication to undergo cardiac surgery to replace a valve, repair a valve, or to have a coronary artery bypass graft. In these patients, we should proceed to surgery rather than the percutaneous treatment. Patients with an established left atrial thrombus or recent thromboembolism We should not proceed to percutaneous mitral commissurotomy before we give effective anticoagulation and we document freedom from left atrial thrombi. Patients with severe and or bilateral commissural calcification have a low likelihood of success and a high likelihood of complications, and these patients are better sent to surgery. Patients with no commissural fusion will seldom benefit from balloon mitral commissurotomy. This is a summary or overview of the indications of percutaneous mitral commissurotomy. One should always bear in mind how small the area is, if there are any contraindications, the presence of symptoms or risk factors of hemodynamic deterioration or systemic embolism. Let's have a look at the so-called unfavorable features. Unfavorable features for percutaneous mitral commissurotomy may be clinical, such as advanced age, NIHA 4+ or severe symptoms, permanent atrial fibrillation as opposed to paroxysmal or recent onset atrial fibrillation, and patients with prior commissurotomy. These groups of patients may not benefit very well from percutaneous mitral commissurotomy. It should be noted, however, that patients with prior commissurotomy may still benefit from redo commissurotomy, provided that the first procedure was successful and there is evidence of recurrence of commissural fusion. There is a list of anatomical unfavorable features, such as non-rheumatic mitral stenosis, scleroderma, lupus erythematosus, for example. Patients with very, very small mitral valve area, 0.6 or something, these patients usually end up with still stenotic valve. Patients with severe tricuspid regurgitation or severe pulmonary hypertension are not very likely to restore a normal competence of the valve or resolution of pulmonary hypertension. The last and most widely used anatomical index to assess the eligibility for percutaneous mitral commissurotomy are a set of scores: the Wilkins score, Commissurotomy score, and the so-called echo score revisited. The Wilkins score, or sometimes called the mitral valve score, is the most commonly used, and it assesses 4 features of the mitral valve apparatus: mobility, thickening, calcification, and subvalvular thickening. Each of these features may be given a score of 1 to 4, giving a maximum theoretical value of 4 by 4, that's 16. A Wilkins score of greater than 8 suggests that the likelihood of the procedure to be successful and safe is relatively low. There is evidence to suggest that even in patients with a high score, there is still a chance of a successful percutaneous mitral commissurotomy, but obviously it's much lower than in patients with a lower score. The Commissurotomy score is a simpler score, and it suggests that if there is any evidence of valvular calcification on fluoroscopy, then percutaneous mitral commissurotomy is not recommended. The recently introduced echo score revisited covers 4 factors or 4 features of the valve and the valve apparatus. That's mitral valve area, maximum leaflet displacement in apical 4-chamber view, commissural area ratio, representing the asymmetry of commissural fusion, calcification, thickening, or commissural disease in general, and the extent of subvalvular involvement. In general, patients with a score of greater than 5 are considered unsuitable candidates for percutaneous mitral commissurotomy. In this very nice study, which tried to validate this score, procedural success was defined as an increase of at least 50% of the mitral valve area or a final area of 1.5 centimeters square or greater, with no marked deterioration of mitral regurgitation as assessed 24 hours after the procedure. On the left-hand side, we can see that in patients with an echo score revisited of 0, the likelihood of suboptimal result is very low, less than 10%. While in patients with a score of 3, for example, the likelihood of suboptimal immediate result is about 50%, and in patients with 5 or greater score, the likelihood of suboptimal result is very, very high. On the right-hand side, we can see that event-free survival was much better in patients with an optimal result immediately after the procedure. So when we stick to the score, we get better outcomes, and this translates into a better prognosis. Let's have a look on the guidelines for the indications of percutaneous mitral commissurotomy. In the ESC 2017 guidelines, the two indications that have class 1 indication are patients who are symptomatic without unfavorable characteristics, clinical and anatomical. The second indication is patients who are symptomatic with a contraindication or high risk for surgery. Class 2A indications include patients who are symptomatic with suboptimal anatomy but who do not have unfavorable clinical features. Class 2A indication also include patients with high thromboembolic risk manifest as systemic embolism or dense spontaneous echo contrast or recent onset or paroxysmal atrial fibrillation, and patients at high risk of hemodynamic decompensation as evidenced by significant elevation of pulmonary artery pressure or planned major surgery or pregnancy. Again, unfavorable characteristics for percutaneous mitral commissurotomy included some clinical and some anatomical features, including the scores we have just mentioned, and the clinical factors including age, prior commissurotomy, and severe symptoms. The 2014 guidelines of the ACC-AHA went more or less in the same direction. And the main indications are still symptomatic patients, patients who are not candidates for surgery, and patients who are at increased risk for thromboembolism or hemodynamic deterioration. Let's cover some of the technical aspects of the procedure. Percutaneous mitral commissurotomy can theoretically be performed retrogradely or transarterial. In this case, an externally steerable cardiac catheter enters into the left ventricle and then across the mitral valve into the left atrium. The much more commonly used approach is the antegrade or transvenous approach, which requires a transeptal puncture. PMC can also be classified according to the used device into NV balloon technique, double balloon technique, and metallic valvulotomy. The most common among these approaches are the transeptal approach using the double balloon or the NV balloon, and the NV balloon is worldwide a bit more commonly used than the double balloon, owing to its ease of use. It should be noted, however, that in terms of safety and efficacy, NV and double balloon techniques are more or less comparable. The transeptal puncture requires very careful guidance, usually using fluoroscopy. Multiple views are usually used to optimize the location of puncture, and the main target is to avoid to be too close to the aorta and the aortic mound, or too close to the free atrial wall or the atrial roof. How to choose the balloon diameter? This is based on two parameters, at least. The first is the patient's habitus, body habitus, the height and the body surface area. And the second factor is the mitral annulus diameter. The mitral annulus diameter in the setting of percutaneous mitral commissurotomy is usually measured in the apical 4-chamber view. Let's have a look at the NV balloon technique. The balloon has two compartments. The first one is inflated within the ventricle, and then the balloon is withdrawn so that its waist snugly fits within the valve, and then the proximal part is inflated within the atrium. And then we continue inflation until we reach the maximum required diameter. The NV balloon's diameter is determined based on patient's height by adding 10 to the patient's height in centimeters divided by 10. So a patient who is 180 centimeters tall will require a 28 millimeter balloon. The balloon size should also consider the annulus, trying to avoid that the diameter of the balloon exceeds the mitral annular diameter. Usually, the balloon is inflated at first 2 to 3 millimeters smaller than the planned diameter, and after each inflation, the mitral valve annulus and the commissural splitting and the degree of MR are assessed, and this is followed by 1 millimeter increment in the dilatation until we reach the desirable effect or significant mitral regurgitation starts to develop. The double balloon technique is based on the concept that there is a mismatch between the round shape of the single balloon and the oval aperture of the mitral valve. In the double balloon technique, there is 1 or 2 exchange length guide wires that are advanced into the left ventricle through the mitral valve. And the valvotomy balloons, who are usually ranging from 14 to 20 millimeter in diameter each, are advanced over the guide wires and positioned across the mitral valve. The multi-track technique has been developed by Bonhoeffer et al. And has been described to use the multi-track system, which is a refinement of the double balloon technique. In this particular technology, a monorail system requires only 1 guide wire, and this is a clear advantage of such an approach. The Bonhoeffer's multi-track balloon is available in sizes from 14 to 20 millimeter. Each balloon is 5 centimeters long, and the balloon catheter is 7 French thick. Another option that is now more or less historical is the Cribier's metallic commissurotomy or metallic valvulotomy. It's worth mentioning that the largest series of such a procedure has been published in 1999, and there has been a significant contribution from Egypt. Some other worth mentioning technical aspects of percutaneous mitral commissurotomy include that TEE should be performed within 24 hours before the procedure, basically to exclude the presence of left atrial thrombi, but also to better assess the degree of mitral regurgitation and to have a look at the interatrial septum, trying to specify a sweet spot for penetration of the septum, as well as to size the mitral annulus. Fasting is a common practice. An IV antibiotic is usually given within few minutes before the procedure, and mild sedation is enough in most adult patients unless TEE guidance is planned. Coronary angiography should be simultaneously performed if the procedure is being done in a patient who is 40 years or older, and anticoagulation during the procedure is mandatory, but only after septostomy is effectively performed, and success is defined as a mitral valve area of greater than 1.5 centimeters square and or doubling of the mitral valve area, provided that mitral regurgitation is not severe. And thank you very much for your attention.